All right. Hi, everyone. Thanks so much for being here. We're going to go ahead and get started. Thank you for joining us for the webinar, Does SBIRT Pay? Measuring Value Beyond Billable Dollars. This interactive discussion will explore how humanizing and addressing substance use is a must in today's world. Universal screening and intervention may serve to yield opportunities to destigmatize, normalize, and humanize substance use. We will explore how to measure value of programming beyond the phantom billable dollars, whose absence can act as a barrier to comprehensive care. We are the School-Based Health Alliance. We work to improve the health of children and youth by advancing and advocating for school-based health care. We believe that all children and adolescents deserve to thrive, but too many struggle because they lack access to healthcare services. School-based healthcare is the solution, bringing healthcare to where students already spend the majority of their time, in school. When health and education come together, great things happen. Attendance improves, conditions like asthma or diabetes are better managed, and behavioral health issues get quick expert attention. And we all know that healthy students make better learners. Now, we have a few housekeeping reminders. All attendees are in listen-only mode. However, we want to hear your questions. To ask a question at any point during the webinar, please use the Q&A tool located in your Zoom control bar. We will address questions following the presentation. If you would like to add your comments through the chat function, please select all panelists and attendees before sending the message so everyone can see it. At the end of this webinar, attendees will be asked to complete evaluation poll questions. Please let us know how we are doing. Your feedback is vital in helping us craft presentations that meet your needs. This webinar is being recorded and will be archived on our website in 1 to 3 business days. Please also visit the School-Based Health Alliance website for additional archived webinars for topics such as the one you are viewing on your screen. Our 2021 School-Based SBIRT Speaker Series is funded by the Hilton Foundation. We invite you to join us for our upcoming sessions. We will drop the registration links in the chat. Next week, we will be facilitating a panel on strategies for innovating the SBIRT model to best meet the needs of adolescents. In early May, we will host a panel focused on the connection between the SBIRT model and comprehensive screening. And we are so thankful to our colleagues at Community Catalyst who have graciously allowed us to rebroadcast 3 sessions for their recent convening on policy advocacy to prevent addiction. We will also drop the links for that in the chat. Now I will hand it over to my colleague, Katie Stinchfield, to introduce our presenter for today.
Thank you so much, Maddie, and thanks to everyone for joining us today, and welcome Dr. Kapoor. Dr. Sandeep Kapoor is an assistant professor of medicine, emergency medicine, and science education at the Donald and Barbara Zucker School of Medicine at Hofstra Northwell, assistant vice president of addiction services for the Northwell Health Emergency Medicine Service Line, and director of screening, brief intervention, and referral to treatment, SBIRT, at Northwell Health. Dr. Kapoor has worked towards strengthening the collaboration between the departments of medicine, emergency medicine, psychiatry, obstetrics, pain management, and pediatrics to integrate protocols to universally address substance use within ambulatory, inpatient, and emergency medicine settings. As of February 2021, the SBIRT program administered 2 million screens during patient visits across 18 emergency departments, 14 inpatient hospitals, and multiple ambulatory practices, resulting in 30,000 brief interventions and 10,000 referrals to care and treatment. Utilizing SBIRT as a foundational framework and gateway, Dr. Kapoor and team are the architects of Northwell's Pathways to Recovery portfolio, including 6 ED-based learning laboratories for medication-assisted treatment, offering layers of support and services for patients and employees in need of care for opioid use disorder. Focused on health professional pedagogy and to address an evident gap in traditional medical education, his team has developed and integrated a dynamic 4-year longitudinal addressing substance use curriculum revolving around early identification intervention within the Zucker School of Medicine. His team has also established a curricular footprint in 6 residency training programs within Northwell. Thank you so much for being here, Dr. Kapoor. I'll turn it over for your presentation, and then we'll follow it with an interactive Q&A session. Thanks so much.
Dr. Kapoor, I think you're muted.
Oh, I do my best work muted. All right. So thank you very much, Katie and Emily, for the kind invitation. It's a complete honor to join you and your group to speak a little bit about what we've been doing here at Northwell, but most importantly, trying to identify the true value of what SBIRT is and has been for us. Let me start off by saying I'm representing a very large team. As you've heard, I'm only one of many, I would say hundreds and thousands within our organization that have been on this mission for the last 7.5 years to not only just address substance use, but actually humanize and address substance use as part of usual care. And hopefully what you're seeing on the slide right now is an illustration of multiple clinical and non-clinical departments playing a role, actively partnering to make sure that we normalize the conversation of alcohol and drugs, as well as we take it a step further and support our patients and our communities. We've also partnered with other external organizations as well as the federal government and the state. So today's conversation is, does SBIRT pay? And I thought it was only right to start off with the reimbursable codes that pretty much almost everyone has seen and probably have had a mixed experience with. It's very difficult to answer that question in terms of billable dollars when it comes down to does SBIRT pay? Because the reality is, even after many years, going back to about 2014, 2015, we're still trying to figure it out when it comes down to billable dollars. But with that said, I do think it's a great opportunity for all of us to collectively explore how do we really measure value. You know, it can be measured by far with some sort of fiduciary component, some financial incentives that we can highlight and illustrate. But for us, SBIRT has really served value in many different forms. So I would like to walk you through about 10 minutes of our journey of understanding what value SBIRT brings to the table. And in doing so, I would request that everybody keep an open mindset. Regardless of your experiences that you've had thus far, I think it would be very important for us to put those good, bad, even good and bad experiences aside for a moment and really just keep an open mind and try to explore further opportunities. And when I say opportunities, I don't mean for yourselves as school-based professionals or healthcare professionals, but really personally as community members, members of very diverse communities that we know that there's no 6 degrees of separation when it comes down to the issue of substance use. I want to put this slide up here purposely because this is a slide that I have the privilege of showing many fellow healthcare professionals. And really it is a call to action that if you are able to keep that flexible mindset, then we are willing to diversify our personal approach. That's the only way we're going to be successful with system level, school-based, community level strategies. It has to come down to each one of us. And I'm hoping that in the next 10 minutes, you'll find the value of SBIRT in making this point true. I think I would be remiss if I didn't share that in the next 10 minutes or so, there may be some triggering things that are said. Knowing that many of us have lost family members or patients or students or community members to this chronic illness. So I just want to let you know right in advance that we're here with you. You're not alone. And at the end of this, hopefully we can take a moment of communal self-reflection. So folks, as we talk about substance use, unfortunately, many of us, we jump to the far end of the spectrum and all we talk about is abuse. And we start using words and talking about people very differently, especially in a way that unfortunately perpetuates stigma and puts up barriers for those that actually need support and help. Dr. Martin Luther King said life's most persistent and urgent question is, what are you doing for others? And as a group full of community-focused, school-focused professionals, you do a lot for others. But if you replace the word others with folks dealing with substance use, it may be a very difficult question for us to answer for ourselves personally, or even for our departments and our environments that we work in. But we need to ask and answer because the issue is stark. 1 in 4 people that started using alcohol, drugs, and tobacco before the age of 18 currently have a substance use disorder, leaving 40 million people, 1 in 7 of us, with a chronic illness that overshadows the prevalence of heart disease, diabetes, and cancer individually. The cost to our economy is enormous. However, it has not been a driver for change. Close to $775 billion for heart disease, diabetes, and cancer combined. And when you look at alcohol, drugs that include tobacco, we're not that far behind at $706 billion, but this has not been a driver for industry-wide or society-wide change. The biggest issue is that our physicians are not trained. The average medical school has less than 4 hours of dedicated curricula. Medical residents feel uncomfortable. Nursing schools are catching up. And our clinical go-tos, our social workers, well, as of 2017, 98% of master social work programs did not require a course in substance use, which unfortunately yields this data point true, that only 1 in 10 people that need treatment for this disorder actually receive it. And the majority of people that do not stem from healthcare or school-based settings. Criminal justice is the #1 referral source. So here at Northwell, my organization, we've come up with a recipe that if we start developing education, we can build motivation and comfort so that everyone can stand up and be proud and serve as a conduit of hope for a disease process that unfortunately is hopeless for many. One way we start in this paralyzing equation is our language. So instead of talking about the substance use epidemic or the opioid epidemic as if it's somebody else's, I would challenge everybody to just change one word, our epidemic, because it is ours. Last year, we lost over 80,000 people due to drug-related overdoses. Just put this in context, in 20 years of the Vietnam War, we lost under 60,000 people. When you look at alcohol, we're every year after year, close to 80, 85,000 alcohol-related deaths. We need to act, but we haven't. And there's no shortage of key players in the reason why we haven't acted. Big Pharma, the hospital, the pharmacies, Press Ganey, the criminal justice system, the FDA, the individual. But as we keep playing this blame game, the only people left to fend for themselves is us, our students, our patients, our families. Let me explain this blame game. The lack of accountability underscores a lack of ownership, which perpetuates a lack of motivation, which fosters what we're seeing, a lack of action. But if you take SBIRT as a whole, then all of us can collectively stand up and say it's time to act. We can utilize SBIRT as an element to motivate a shift in culture, to represent and appreciate substance use as a healthcare issue it is, to raise awareness, build skills, and comfort. It also allows us to realize that this is a public health crisis, and there's more people at risk than they're actually dealing with dependency or an addiction. And the face of addiction that we may stereotypically think that we know is not true. It could be any one of us. You know, as healthcare professionals, that should be empowering. We could prevent the progression of a very chronic condition. Let's put this into context. Everyone understands type 2 diabetes, and everyone understands that you don't just wake up one day and you're diagnosed with type 2 diabetes. There's a journey from pediatrics to geriatrics, and we screen and intervene and treat every step of the way we can to prevent the progression of that disease. Substance use is no different. And if you look at SBIRT for what it really is, not this alien term, but all we're doing is screening for a substance use disorder, intervening at every single touch point and providing treatment or a referral to treatment. That's the beauty of SBIRT. Another realization we have to come through is that SBIRT can start normalizing the fact that recovery and well-being is achievable. The reality is there's 21 million people in recovery, and that thoughtful, compassionate, motivational interviewing conversation could be the start of changing someone's trajectory towards well-being and recovery. Another thing that SBIRT has brought value to is really demonstrating that there's a landscape of addiction care. It's not just detox and rehab, probably the hardest two to get someone connected to. There's a whole outpatient world out there. And if you have high blood pressure, I'll put this into context, you're probably not going to see an interventional cardiologist tomorrow. You're going to go to a primary care doctor. Same with substance use disorder. You could start with outpatient. Another thing SBIRT has allowed us to do is to normalize that recovery is not a straight line. And if we can infuse compassion and acceptance, we can be there to not only normalize relapse, but still be partners. And that's what SBIRT's allowed us to do. Lastly, and I think the most critical point, SBIRT has allowed us to normalize our language, to humanize our language and use person-centric language readily, instead of the knee-jerk words like addict and alcoholic or talking about someone's drug screen being dirty or clean. The reality is, with processes like SBIRT, we can infuse so much different terminology that really serves as facilitators towards someone's well-being as opposed to barriers. So with that said, I want you to think about how you can utilize your SBIRT mission to reframe the conversation to create action and advocacy. But I will be honest with you, after 7.5 years, there's still tons of challenges. But every single challenge is an opportunity, like I said before, for you, your family, my family, our communities, and our industry at large, be it the school industry or the healthcare industry. Now, I would be remiss if I didn't say this clearly, but frankly speaking, substance use and the substance use epidemic has affected certain communities more than others over the years, especially communities of color. We cannot avoid this, but you can look at SBIRT as a way to motivate folks not to forget the past, but motivate them to act now, to partner, to innovate, to correct. It is our time now with SBIRT to provide care and social justice indiscriminately, universal protocols, screen everybody. It is our time to right the wrongs of the past and replace that despair and hopelessness with actual compassion and equity. It is up to us to eliminate disparities of care and justice, and really, these kind of SBIRT protocols really play a big role. So I like describing SBIRT as a journey, and we have an SBIRT compass here that we've used, and it's deep stewed in compassion, acceptance, respect, empathy, and justice. And with that said, if we can think about really finding the true value in protocols and processes like this, we can continue to humanize this topic, destigmatize it. We can disrupt those industry norms that we've all had to follow for years. We could accept substance use as the healthcare issue it truly represents, build partnership amongst ourselves, our sites, our patients, our students, and every one of us can stand up and serve as a conduit of hope for a disease process that unfortunately serves to be hopeless for far too many. I'm going to stop here. That was a lot of information. I do think that it would be appropriate for me to humbly request everybody to just take a moment, close your eyes, think of that one person you know. It could be a student, it could be a family member, it could be a fellow colleague, someone down the street, and just close your eyes and think about the struggles that they've had to deal with, or even that you've had to deal with. And what I would ask is just think about what you would want to do differently moving forward. Okay, I want to thank you for that shared vulnerability. I want to thank you for making a commitment. I'm going to stop here and I'm going to ask Katie, I'm going to hand it back to you and to Emily, and I'm more than happy to chat a little bit before we go a little bit deeper into the slides.
Great, thank you so much for that. And if we have any questions from the attendees, we'd love to hear them now. So feel free to add them to the Q&A or the chat, and we'll ask those of Dr. Kapoor. Thank you so much for that presentation.
Yeah, absolutely. Thank you for having me. And I hope, hopefully some of it resonated with our colleagues that have joined us today.
I'm going to give the chat just a second to see if any pop in for you at this point.
Sure.
I see a question that says, how can we utilize the SBIRT model as not only an assessment for risk, but also a way to celebrate healthy decisions?
Yeah, I think that's a great question. Debbie, thank you so much for framing that question for everybody. You know, I think that's the beauty of this model. There has to be flexibility in how we approach it. If we were to only talk about this as an opportunity to identify when someone is at harm, in harm's way, or dealing with an addiction, we're really losing the bulk of the spirit of what SBIRT is. You know, I showed before there's a spectrum, and the beauty, if SBIRT's done appropriately, in a non-confrontational, non-judgmental manner, we can not only celebrate when someone is doing better with their substance use disorder, but also inform and validate folks that, let's say, may be abstinent or maybe utilizing alcohol and drugs in a manner that's not putting them at extreme risk or added risk. An example of this would be the normalization of healthy drinking guidelines, right? So if you were to screen somebody and let's say they were screen negative, meaning they're not at the risk level of alcohol use disorder, but they are utilizing alcohol, even having a thoughtful conversation, validating that they are sticking within the healthy drinking guidelines, educating them on it, because frankly speaking, many healthcare professionals don't even know what the healthy drinking guidelines are. That in itself is an opportunity to build partnership. And when I say that is because the reality is with substance use, it can change in a moment's notice, right? So one day someone could be drinking below the healthy drinking guidelines. The next day they may have an issue with their spouse, lose their job, fail out of school, or just have a lot of stress in their life. And if we don't continually engage folks and give them the opportunity to talk to us, we're not really serving as partners. We're really looking at this as a one touch, let me figure out what's going on with you and potentially hand you off to someone else.
Thank you so much, Dr. Kapoor. And I also appreciate that question, because I know we see that so much working in the school-based setting that often we're not seeing high-level use, but it's a great opportunity to offer that positive reinforcement for making healthy choices for students. I see another question asking you to talk about the community of color impacted the most. If there's enough people of color providers who understand the racial trauma that value substance use as healthcare to recovery.
Yeah, thank you, Samantha, for the question. I think the easiest way to answer that is that we need to keep enrolling, recruiting, motivating anybody and everybody that we can, regardless if they are a healthcare professional or not, to be part of these journeys. We've found a lot of value in not really having the quote unquote provider, the doc or the NP or the ACP being the main champion or the force behind this. We've seen a lot of value in our diverse medical office assistants, our nursing team, everyone working in harmony. And frankly speaking, I think if we were to stay blind to the trauma that substance use disorders create for families, as well as for the individual that's struggling with that chronic illness, I think we're much further behind than we need to be. We need to understand that there is trauma related here. We need to infuse trauma-informed care. We need to be sensitive and thoughtful to understand that, yes, again, the substance use epidemic is affecting everybody, but there are many communities that have been heavily affected by this, and there's been a lot of inaction from the government, from the healthcare system, from even communities themselves and local leaders. So I guess I don't really have a direct answer to that other than saying, I think the only way that we can make a change here is to harmonize, meaning get as many people involved to start speaking the same language and seeing the value in addressing substance use as part of usual care, using evidence-based screening that SBIRT provides.
We have another question from Catherine that's similar, talking about how addiction and its perception can look different within communities of color or high poverty communities, if you want to follow up on that at all.
Yeah, and I would love to open that up to the group as well. I mean, feel free to comment on Catherine's question, but I think perception unfortunately serves as a big barrier for folks to seek support, for folks to access support. I mean, frankly speaking, even though all of us are on this webinar together and have some sort of shared commitment, we're all different people. We all come from different cultural backgrounds. There are certain cultures that don't even want to talk about addiction or substance use. It's just non-existent. And I would actually say the one commonality that many of us do share is the fact that when we were younger and sitting around the dinner table, at least, I mean, I'll just speak for myself, but sitting around the dinner table, this conversation of substance use, regardless if it was in our family or not, extended or the nuclear family, this was a conversation that was hidden under our dinner table. Like, we didn't talk about it. We talked about it in very stigmatizing ways, like that quote unquote drunk uncle or that kid down the street making the wrong decisions. It was never really at the table. It was under the table. And then fast forward to today, many of us are wearing hospital IDs or school IDs, and all of a sudden we're supposed to be compassionate and we're supposed to understand the struggles that people are going. But the social primers that we were brought up with have brought us to where this industry's at, which is we do have a lack of patience, a lack of compassion. We have a tremendous amount of stigma, and these are all driven by the perceptions that we were brought up with.
Thank you so much. I see another comment. We know medication-assisted recovery can be effective. However, we still end up referring individuals to recovery after treatment to 12-step programs. The 12-step groups still tend to be the only show in town and often frown on medication-assisted recovery.
Yeah, that's interesting. And, I think I think everyone's journey is independent and unique, and we need to respect that. The reality is there's a lot of value for MAT. There's a lot of value for 12-step programs. There's a lot of value for other offerings in terms of supporting someone through their journey towards well-being and what they feel is recovery. I don't know about your local area in particular, but yeah, even our team here, I mean, we refer and offer resources of community support left and right because we know that it's hard to be alone. Frankly speaking, COVID has brought this to even more of the forefront. It's hard to deal with a stigmatizing disease process without a support structure. And that support structure may not always be our family. It may actually be the exact opposite, where many families aren't open and willing to support their fellow family members. So I actually think there's whatever options available is better than no option, to be frankly honest. But I do think that there are evidence-based processes that we could at least utilize to get people to the right place. And that's, again, to me, where SBIRT holds a lot of value. If we're able to insert some sort of objective approach to screen, to intervene, and to better understand what consequences an individual is dealing with, because it is their individual consequences that we need to pick up on and to recognize and to appreciate and to acknowledge, but then also figure out pathways how we partner with them to get them to whatever care it is, be it traditional addiction care, medications for addiction treatment, 12-step programs, whatever they want to start with is better than not starting at all.
Thanks so much. Yeah, so important to talk about the different options available to people. We have a question about school services. So who would you suggest be contributors to make up an effective healthcare team to address substance use in schools? I'm happy to chat about that a bit, if you don't mind, Dr. Kapoor.
Please.
So the School-Based Health Alliance has been doing an SBIRT in school-based health centers project for years now. And obviously with our model, we have a school-based health center in the school. So ideally a primary care provider, a behavioral health counselor who can address both mental health issues and substance use concerns, as well as maybe some other support staff, sometimes a robust team that includes oral health care, dermatology, a variety of things. And so for our model, we really look to that team to collaborate with school staff, which might be a school counselor or school social worker, other folks working in the school administrators, to come up with a plan to do SBIRT in the school-based health center, and then also consider some other options like using SBIRT as an alternative to suspension, making substance use screening routine for young people, and honoring positive choices, as well as getting those supports in very early before full addiction transpires, and as well as working with the school personnel and sometimes the school or the district to really evaluate those discipline policies and remove some of that punitive process for substance use and get young people the help they need. So happy to talk more about that anytime, and we have a ton of resources currently and a toolkit coming on our website this fall. So more on that soon.
Do you mind if I comment on that? So, because I do think that one thing that resonated with me that you just shared about all these different strategies, and I love the fact that there's so many different strategies, right? Like there's so many different options for folks to get started and to continue or to grow. But the one thing that resonated with me was that approach of universal screening, right? Because that in itself serves as a mechanism to normalize this conversation, right? Because if we were to agnostically, regardless of what someone looks like, regardless if they got in trouble, regardless if their presentation or their disposition, is one of those stereotypical ones that we think we understand so well around substance use, if we were able to create universal screening so that whoever is being screened can also gain their own insight and appreciation for the value of being asked these questions in a safe setting, right? Be it a clinical setting or a school-based setting. So I just wanted to just share that because that's been our strategy as well. Universal screening, we ask everyone, and it was a purposeful strategy because we wanted to make sure that this was going to be part of usual care or our usual patient care, as opposed to ad hoc, we decide when we want to do it and so on.
Yes, totally agree. And that's what we advocate for normalizing and for just making it, again, routine that everyone is screened for it. I put the link to our initiative in the chat. I also see a follow-up question, around what if you don't have a school-based health center? Is it appropriate for school counselors, and what permissions would be needed? So as with anything, it's possible to do SBIRT in schools. I'll put another link in where Massachusetts mandated universal screening for students in their school setting, and tapped a different team. So sometimes school-based health centers, and sometimes school staff like school counselors. And so they have a lot of resources. They're learning a lot as they do that. But as always, I would defer to your district and your ethical standards for your practice. So if you're a school counselor, looking to the American School Counselor Association for guidance, and really being careful with making sure that you are the appropriate person to be doing that. And I think so sometimes it might be you, sometimes it might be you advocating for that. So I'll put the link to the Massachusetts project in the chat. And then Dr. Kapoor, I see another question on thoughts on how the pandemic might make youth more vulnerable from the trauma in this experience, and adults modeling handling stress from the pandemic through open use of alcohol. Yeah,
I mean, it's a very relevant question in the times that we're living in. If you look at the data, alcohol sales have skyrocketed during the COVID pandemic. And I mean, frankly speaking, alcohol has been a go-to for us as a society, as a coping mechanism. I think isolation plays a big role. So if you go outside of alcohol, for example, and you think of just the increase in drug-related overdoses, utilizing alcohol or drugs alone, as opposed to when you may have been around others that may have been able to call for help, or use naloxone, which is also known as Narcan, the rescue medication for opioid overdose. I do think the epidemic has caused or precipitated a lot of the current alcohol and drug use levels that we're seeing, as well as the unfortunate loss of life that we're seeing related to that. When it comes down to kids, when you look at school closings, the disruption of their social settings, their ability to connect with others, all of this plays a role, just like it would for us in terms of our decision-making around alcohol and drug use. So I think, if anything, it should be yet another call to action that we need to do this kind of work now more so than ever, so that we're giving individuals the opportunity to talk to trusted, non-judgmental, non-confrontational individuals to seek partnership. We did not with COVID step aside, as healthcare professionals said, figure it out for yourself. But the reality is, when it comes to substance use, we have, as an industry, been doing that to some degree.
Thank you so much. I see a couple other comments in the chat where participants have been doing SBIRT screenings in different ways in the school setting. So if you have a little more information, or a web page, or anything you can share, that would be great to share with the group in the chat. I do want to take a moment and give Dr. Kapoor a little space to circle back and share what they've been doing at Northwell Health as part of their SBIRT work.
Yeah, absolutely. More than happy to share that. And again, I would just start off with some honest comments about this. One, even though we've been doing this for 7.5 years, and we have a huge team behind this, I'm the first one to say that we're still in our infancy. And the reason I say that is not to discredit or to undercut any value that we've brought to the equation. But the reality is, this is a multifactorial, complicated issue that we need to keep innovating to strive to get to where we really want to be. So with that said, what I'm going to show you on paper looks really good, but I want you to know every single day we have team members that are troubleshooting to make sure that this is sustained, as well as that we're able to keep growing. So let me tell you a little bit about Northwell Health. Northwell Health is the largest private employer as well as healthcare provider within New York State. And our region really is downstate New York State. So Westchester, Long Island, if you're familiar with the geography, and the 5 boroughs of New York City. The reason why I say private, the largest private employer, I think it's really important, because one of the things that you may face, regardless if you're in a school-based setting or a hospital setting, is you may face pushback from your colleagues about a process like SBIRT, but we need to really appreciate and digest that a little bit. Because like I mentioned before, there's no 6 degrees of separation, and many healthcare professionals, school professionals, no matter what setting you're in, may be dealing with a substance use disorder themselves. So I think it's really important to also look at SBIRT, not just a strategy for the population of focus that you're thinking about, which may be your students or maybe patients, but also think about the value of utilizing SBIRT with your employee health folks, so that we are supporting our colleagues through their journey, because it is a pretty prevalent healthcare issue. So one more thing about this, when I look at a slide like this, for us, it served as a petri dish, the best petri dish ever, to really try to enact small actions of change and seeing what sticks and what doesn't. So I will show you some of our successes, but I promise you, every success we've had, we probably had 10 failures that have led us to better appreciating and understanding how to keep developing. So that's another thing I would just throw into the mix here. I'm very proud to say that as a healthcare industry, as a healthcare system, we have a strategy around addressing substance use as part of usual care. And that may not sound like a really big thing, because you think big organizations have strategies, but 7 years ago, I don't think we really did have a strategy in place. But because of SBIRT, we now have a foundational strategy that we keep building layer and layer and layer on top, and utilizing SBIRT as the gateway to this. And I'm going to describe this in a second. So the best way to probably describe it is like building a house. And I'm sure there's not many general contractors on the phone with us today, but everyone knows how to build a house here. You know you need a foundation, and our foundation has been screening, brief intervention, and referral to treatment. Our We Ask Everyone protocol is true to its name. It's universal screening amongst 18 emergency departments, including our children's hospital, 14 inpatient facilities, as well as a wide network of ambulatory care. Every single time we're going to take blood pressure as a vital sign for cardiovascular disease, we're taking a vital sign to understand risk factors for substance use disorder. And that's in the form of asking a couple of evidence-based questions at every single touch point that we have with patients. To date, as you heard earlier, we've completed over 2 million screens in 7.5 years. And I don't want to frame it as screens. I want everyone to really think about this when talking about value. That's 2 million opportunities we brought to people in need to talk to a trusted team member about their struggles with alcohol or drug use. This foundation has been critical in building this house of strategies. Every house needs framing, and our framing has been in education. When we went out to actually train and educate team members to ask 2 to 4 questions of patients, what we thought was pushback was actually discomfort, because we're not educated. Physicians, nurses, social workers, the list goes on. We have a severe gap in traditional healthcare professional education. So what we did with our SBIRT program, in order to make it successful within our healthcare system, we first went back into our medical school and our School of Graduate Nursing and built education. We evaluated that education and brought it back into our health system so that we can actually comfortably educate people and train them and bring them to a level of comfort. The second layer on top of our house of strategies has been something called NowSat. So I mentioned naloxone and Narcan before. This is a low-hanging fruit, and SBIRT serves as a perfect gateway to educate people how to prevent fatal overdoses. The majority of opioid overdoses pre-COVID were witnessed. So if you think about that, that means there's an opportunity there not only to just save the life of the individual, but the lives of their community, their school, their churches, their families. So what we do here is via our SBIRT program, we offer education on opioid overdose prevention, and we actually hand over, thanks to New York State Department of Health, free of charge naloxone rescue kits at point of service. And since we started this program about 4.5 years ago, we've given out close to 6,500 kits within our emergency departments and out in the community. The third layer is MAT. Someone mentioned medication for addiction treatment before. And we know very well that the healthcare industry works in silos. We're trying to break down those silos so that we can treat the addiction right at the point of service when someone's in an emergency department, and then hand them off to our colleagues in addiction treatment. We don't need to wait anymore. We can actually start that process the same way we would start to treat someone's heart disease, someone's diabetes, and so many other chronic illnesses. We don't wait for the consult. We start the process and then we connect people to care. And let me just talk about connecting people to care, because I think SBIRT has served us really well when we talk about something like Project Connect. And to me, in this house of strategies, that's the roof. And the roof of our homes keep us dry, they keep us safe, they keep us connected. So Project Connect is our iteration of a longitudinal care navigation platform, so that once someone leaves our emergency department, we don't let go of them. We will assign a navigator to be by their side to help them through their journey of that landscape of addiction care so that they can find well-being and recovery. They have someone on call by their side 120 days post-discharge. And what we found through this process of starting this conversation with SBIRT, this has allowed us to have continuity of care. It's allowed us to continue this conversation beyond those four walls of our clinical settings. And if anyone that's currently doing SBIRT right now, unless you have an understanding of what happens to that patient 10 days later, you start losing buy-in of your frontline team members, because they don't really see the value. They don't see people doing better. They don't see people in recovery, or we don't have the opportunity to really understand, again, that recovery is not a straight line, and we may need to bring them back in to have another conversation. Let me talk about education, because I think, again, everybody that's invested in SBIRT that's here today, you have to understand how much value your project, your willingness, your motivation brings to the table, because you can start changing education at your own environment, in your hospital, in your school, whatever it may be. But just think about the value of filling those gaps and taking those social primers and stigmas that even myself have come to the table with and replace it with science and evidence. One other thing I want to share is, because of SBIRT here at Northwell Health, we've been able to trigger many different conversations. We've been able to motivate top senior leaders to change policies that were driven around substance abuse, and now they're framed as substance use. Employee-facing policies, we've been able to drive 76,000 fellow Northwell colleagues to go towards making a pledge. This QR code was developed for you guys today. You could feel free to take your camera and scan it, and you could take our pledge to humanize substance use. But what we asked of 74,000 employees back in July was to take 12 minutes of their time, watch a video, keep an open mindset, and work towards this mission of reframing the conversation, really supporting what we're trying to do with that SBIRT touch point. Lastly, I'll say we need to be extremely volatile and flexible. And when it comes down to it, when COVID hit, all of our inpatient care went out the door. Figuratively and literally went out the door. We couldn't be on site. So we created telephonic SBIRT, we created telehealth with video conferencing SBIRT. We've been trying to do whatever it takes so that folks aren't left to fend for themselves for a chronic illness that already they probably were having a lot of struggles with finding supports. With that said, I'm going to say one thing. The spirit of MI that we utilize in the brief interventions, it's all about this. It's not about pushing people to do something that we want them to do. Stop drinking, stop using drugs, whatever it may be on our agenda. It's about finding what motivates them. And I got to say, for 110 people that have joined today that think SBIRT is worthwhile, well beyond the billable dollars, please take a moment to acknowledge and appreciate that protocol for SBIRT for substance use can serve to motivate the masses to start humanizing this topic that is so stigmatizing and so debilitating for many. I'm going to stop there, Katie, and hand it back to you.